Well, good morning, good afternoon, or good evening, depending on where you are. We're going to begin the last session, the last scientific session of the Congress, and then we will have the plenary session for closing. I hope you've been interested and you have learned a lot, because it has been a very intense 3 days and I think really interesting. And in this last session, we are going to go through some oral communications that have been selected to present orally. We are moving to the next speaker. This is Professor Satoshi Kawashima. He's the clinical study manager from GCR Pharmaceuticals, and he's going to talk us about the clinical trial of blood-brain barrier intravenous crossing enzyme in MPS type 1. Professor Satoshi, thank you for coming, and when you want.
Okay, thank you. Can you hear me? Okay.
Yeah, you can begin.
Okay. Thank you for your kind introduction. I'm Satoshi Kawashima from JCR Pharmaceuticals. It's an honor to be given this opportunity to show the preliminary results of the clinical trial with JR171 for mucopolysaccharidosis type 1. JR171 is the application of our technology of delivering enzymes across the blood-brain barrier. And its phase 1-2 study is ongoing in Japan, Brazil, and the US. MPS 1 is one of the lysosomal storage diseases caused by malfunction in the alpha L isolinase. This results in accumulation of glycosaminoglycans in cells throughout the body. MPS 1 is an inherited heterogeneous disease with a broad range of symptoms as shown here. In particular, degree of neurological symptoms is greatly different among patients. The left column shows 3 types of MPS 1 and their features. Sheye syndrome and Hara-Sheye syndrome belong to the attenuated type. They have no or mild CNS symptoms. The most severe type is called Hara syndrome, which has severe CNS symptoms. The patients with Hara syndrome develop symptoms in infancy and usually die within the first decade of life. Currently, we have 2 treatment options for MPS 1, ERT and HSCT. ERT improves somatic manifestations but cannot address progressive neurodegeneration because of the blood-brain barrier. On the other hand, early HSCT is reported to stabilize the CNS symptoms, but may involve fatal complications. Therefore, a novel treatment is needed for CNS symptoms in MPS 1. JR171 is composed of anti-transferrin receptor antibody and an enzyme, IDUA. JR171 can enter the brain through endothelial capillaries by transferrin receptor-mediated transcytosis. At the same time, JR171 can enter somatic cells by mannose-6-phosphate receptor-mediated endocytosis, because JR171 incorporates mannose-6-phosphate. In short, JR171 is effective not only for somatic symptoms, but also for the CNS symptoms in MPS 1. The phase 1-2 study consists of 2 parts in order to evaluate the safety, pharmacokinetics, and the exploratory efficacy of JR171. In part 1, 4 subjects aged 18 years or older are intravenously administered with JR171 in a dose escalation manner for 4 weeks in Japan and Brazil. Part 2 will administer JR171 at either low or high dose to at least 14 subjects, including pediatric subjects, for 12 weeks in Japan, Brazil, and the US. We had already completed the part 1 and are now conducting the part 2. The subjects who complete the part 2 can continue their JR171 in the following extension study. Here are the major inclusion and exclusion criteria for the study. As I mentioned, only adult subjects can participate in the part 1, while the pediatric subjects can only participate in the part 2. Inclusion criteria are the same for both part 1 and 2, namely patients who have previously been treated by HSCT, or patients who have received ERT for at least 12 weeks. And let me show you some of the data from the part 1. As you can see, 2 subjects were enrolled in Japan and Brazil, respectively. The Japanese subjects were older than those in Brazil. All 4 subjects were female and diagnosed as Sheye syndrome. They had no prior HSCT treatment and have been treated by laryngees for more than 10 years. And next, this slide shows the plasma concentration of JR171. One subject, so subject 2, did not show clear increase in maximum concentration, but those dependent increase in plasma concentration was detected in all subjects. JR171 was eliminated in the next day after the administration. As an exploratory endpoint for the efficacy against the CNS symptoms, we measured heparan sulfate concentrations in the cerebrospinal fluid. HS markedly decreased in all 4 subjects following the JR171 administration. The average reduction ratio was 65%. This means that following intravenous administration, JR171 reached the brain and worked there, which resulted in degradation of substrates in the brain. Regarding the efficacy on the somatic symptoms, HS and DS concentrations in serum and urine remained stable throughout the study period. This means that when all subjects were switched from laryngees to JR171, comparable somatic efficacy has been maintained. Now, safety data obtained so far. No problems in the administration itself. There were no adverse events in the blood tests, including hematology and iron-related tests, urinalysis, electrocardiogram, and vital signs. Regarding infusion-associated reactions, there were 3 events in 1 subject. The events were the same, namely mild redness of the skin, which resolved within the day of injection. In summary, phase 1-2 study has been conducted in Japan, Brazil, and the US. The part 1 results suggest that JR171 is safe and efficacy has been suggested for both somatic and CNS symptoms. Based on these encouraging results, we are preparing for a phase 3 pivotal study to establish long-term safety and efficacy. You can find more details on this study on the clinicaltrials.gov website. So, thank you very much for your attention.
Thank you very much, Dr. Satoshi. We will wait 1 minute to see if we have any questions. Well, there's one question about clinical effects, but I imagine that you cannot talk about the clinical efficiency yet of the program, or can you give us some data?
Could you say that again, please?
If you have some clinical data from the patients.
Yeah. Yeah.
Or is it too early to have? And there's another question that when will the study be available in Europe?
Yes. In the phase 1-2 study, we are only conducting Japan, Brazil, and the US. But in the phase 3 pivotal study, we are planning to the target country, including Europe.
Okay. Okay, thank you. So we will hopefully have the study in Europe for phase 3. And for then we will have already some clinical results that hopefully will be very promising. There are no more questions for the moment, so thank you. If we have time at the end, we will do a whole questions again, answer and question. If there are more questions during the next talks, we will address them at the end of all the talks. So thank you, Dr. Satoshi.
Yeah, thank you very much.
Well, we have, I think we have been able to have Paul back with us. Welcome back, dear Paul. The next speaker is a pleasure for me. I think he doesn't need any introduction, but I will introduce in case somebody doesn't know him, Professor Paul Harmot. He's a professor of pediatrics in the University of California in San Francisco. He has a large experience in lysosomal and MPS patients especially, and he's the medical director of the pediatric clinical research program in MPS. He's going to talk us about the gene therapy for severe MPS 2 patients. When you want, Paul, thank you for being back.
Thank you, Maria. It's intercontinental communication. Good thing you have a backup computer. But let's see if I have control of the slides. My disclosures. MPS 2 is well known to most of the audience. We've talked about it for 2 days, but it is a lysosomal storage disease in which glycosaminoglycans or GAGs accumulate in all tissues as a result of missing hyaluronate 2 sulfatase. And it's important to appreciate that 75% of these patients have severe neurodegenerative disease. There is an approved enzyme replacement therapy but it does not cross the blood-brain barrier and therefore cannot help the neurodegenerative disease. This slide summarizes the clinical trial design. RGX-121 is an investigational gene therapy. It's intended to deliver a functional human IDS gene to patients with severe MPS 2. RGX-121 utilizes the adeno-associated virus type 9 vector containing the IDS transgene with the CAG promoter. RGX-121 gene is administered with a one-time injection directly into the central nervous system. An immune suppression regime is in place for the first 48 weeks post-dosing, and 3 doses are being tested in patients 4 months to less than 5 years of age. The primary endpoint shown at 24 weeks is safety, with follow-up for 104 weeks to look at safety, neurodevelopmental assessments, and CNS and systemic biomarkers. This slide provides some background to the procedure and preclinical work that was summarized beautifully by James Wilson yesterday. It's as you can see from this diagram, the primary method of administration is by intracisternal injection provided by guidance, either CT, primarily CT, and completed by either a neurosurgeon or a neuroradiologist trained in the procedure. As Dr. Wilson showed, the vector can be detected in large animal models or preclinical tox studies throughout the areas of the brain and in systemic distribution as well, including liver, spleen, heart, bone marrow. I'll refer you back to his studies for details on this. If the IC administration route is not safe or has a contraindication on screening MRI, we are now able to move to an ICV administration. It hasn't been used in the data set that we're presenting today, but has been used in an MPS I trial by the same sponsor. As of mid-April 2021, there's 9 patients have been enrolled in and dosed in this trial. Their ages range from 5 months to 59 months. They have a variety of mutations, all severe, including 4 missense, 2 gene inversions, 3 frame shifts, and 5 of these 9 patients have now reached 48 weeks, discontinued their immunosuppression. There have been no SAEs related to study drug. At 48 weeks or 52 weeks, the protocol allows discontinuation of ERT, and we've had 2 patients that were described that have discontinued. We also have 2 patients that were enrolled that were naive and did not receive enzyme replacement therapy. Moving to the biomarker results from the CNS, the first biomarker looked at was heparan sulfate. As you can see, it is elevated in cohort 1 and cohort 2 patients, shown dark blue for cohort 2, light blue for cohort 1. With treatment, the CSF heparan sulfate moved below what is felt to be the maximum attenuated level in attenuated patients. Slide, we show a specific component of the heparan sulfate that's shown to be elevated in murine model of MPS II from Brian Bigger's laboratory. You can see that the D2S6 molecule or component of the heparan sulfate is elevated in both groups and shows a response similar to the total HS with decrease over the first 24 weeks. The cohort 2 data stops at 24 weeks, so we will be able to follow up in future presentations with a time course for this cohort 2. And we have 1 cohort 3 patient dosed, but no data showing at this point. It's too early. We did note, and we don't show the data, that CSF I2S protein concentration was found in all patients in the cohort 2, evidence of production and enzyme production by the transgene. Moving to the neurodevelopmental clinical correlate to the biomarkers, we're showing the Bailey scales of infant and toddler development, third edition on this slide. This is the cognitive component of the test battery. As you can see, cohort 1 in the light blue, cohort 2 in the dark. 4 of the 5 patients show improvement after treatment, and the oldest patient shows stabilization. The additional components of the Bailey were tested, including language and motor domains, and see on this slide that 5 out of 5 patients showed improvement, including improvement in communication in the patient that was stable on the previous slide, the oldest patient. As shown in the preclinical studies, there may be a systemic distribution. This is the initial data looking at whether we were seeing systemic effects of the CNS administration. And here we're looking at the urine GAG as our first marker. You can see the 2 naive patients in dark blue have high levels. They drop 55 to 60%, which would show us a strong systemic effect. The 2 patients that have discontinued ERT at 52 weeks, you can see they remain stable, suggesting again that there is a systemic effect. And then the rest of the patients that are still on ERT have shown a small reduction after addition of from a very low level, as shown in the light gray. The second systemic effect that we're looking at is plasma I2S protein concentration. You can see there's wide variability, but all patients did show increases in the plasma I2S protein concentration. We suspect that much of the variability in responses may be related to anti-drug antibody, ERT antibody. So in summary, the RGX-121 appears to be well tolerated. We were able to dose without having any SAEs related to the drug, the study drug administration or the drug itself. Immunosuppression has been completed in 5 of the 9 patients. Biomarker neurodevelopmental assessments are indicated encouraging response, with 4 or 5 showing improvement in cognitive test, and the 5 out of 5 showing an improvement in the remaining components of the Bailey. And then emerging early data suggests that we have a systemic response to the CNS administered treatment. So my acknowledgements, I just want to acknowledge my other investigators participating, Maria Escolar, Roberto Giuliani. The Genix Bio has shepherded this trial through the first 2 years beautifully, and all the study coordinators and most of all the patients who provide such a high commitment and to both their families, their children, and this study. Thank you.
Thank you, Dr. Harmot, for your nice presentation. We have a few questions. One is regarding inflammatory biomarkers. Did you measure other biomarkers apart from heparan sulfate, and especially inflammatory biomarkers because they're predominant in some CNS involvement?
We don't have any release data on the biomarker, on inflammatory biomarkers. It's a good suggestion, and I'm sure that Regenix will move in that direction with the samples. So. And
another question that it was already discussed yesterday, no? But now seeing that the better effect is in the younger patients, would this justify the newborn screening for MPS II, no? Because it's not included in as a general MPS neonatal screening, but do you think it should be included in neonatal screening?
I think it definitely should be included even before effective brain therapies. We do have an effective therapy with improved outcomes and started early. There has been an application submitted in the United States to the Health and Human Services Genetic Screening Committee, and it's been accepted for review. So over the next year, a detailed review will be completed, and hopefully it'll be approved. But I think that it's going to, as with all of the CNS diseases, it's really important to start before, I agree with you, before onset of disease, and you'll get your best outcome with the young patients.
Okay, this another message that is only thanking you for your speech and for your devotion to patients. So I imagine it's a family who is sending messages. And then there's another last question. When the phase 3, one in Europe, is the study still open, or are you receiving European patients?
We are able to receive patients from outside the country. So we have both. This was the under 5 study. There is an over 5 gene therapy, very similar project initiated much later. But as you can imagine, there's so few slots, and there are many patients that really are interested and would be happy to volunteer. It's heart-wrenching to have to work with very few spots, and I can mention patients that it's a very slowly progressing therapy into trials because of the safety examination between every patient makes it move much more slowly than they're used to seeing with enzyme therapy trials that we've had in the past. So there may be 2-month delay between each patient, and it seems like it takes a year to gather part of the cohort. So I thank the families for all of their interests, and hopefully this will speed up as more and more information and safety data comes through.
Thank you very much, Professor.
You heard that. I tend to mumble. I apologize to the translators. It's better in person. Next 2 years from now, it'll be a much easier way to interact and provide information.
Well, we hope we can see you soon in person. Thank you very much.
Good. Thank you.
We are moving to our next speaker. Next speaker is Sarei So. She's a researcher. She's a research coordinator in GCR Pharmaceuticals, and she's going to talk us again about enzyme replacement therapy that crosses the blood-brain barrier for neuronopathic and non-neuropathic MPS II. Thank you, Sarei, for being here, and we are ready to listen.
Thank you very much for the introduction. My name is Sarei So from the JCR Pharmaceuticals. Today, it's my great pleasure and honor to present the recent clinical data of JR141, a blood-brain barrier BBB penetrating enzyme for MPS II. JAD141 is a fusion protein that consists of anti-human transferrin receptor antibodies fused with the two molecules of enzyme. After intravenous infusion in somatic organs, JAD141 enters the cells by two channels, M6P receptor-mediated endocytosis or transferrin receptor-mediated endocytosis. In the brain, JAD141 enters the cells by transferrin receptor-mediated endocytosis. In this slide, let me review the development history of JAD141. In Japan, we have completed the phase 1-2 study and the phase 3 study. In Brazil, we have completed the phase 2 study. Based on the data obtained from this study, in Japan, the marketing approval was granted in March this year and launched this May. In Brazil, as of December 2020, application for the marketing approval was filed. As a next step, we are preparing for the global phase 3 study that is about to start this summer. In this slide, I'm showing the study design in Brazil and in Japan. In Brazil, 20 patients were enrolled in the phase 2 study. In this dose-finding study, patients received either 1, 2, or 4 mg/kg per week of JAD141 for 26 weeks, and all the patients received 2 mg/kg per week of JAD141 in the extension study. In Japan, 28 patients were enrolled in the phase 3 study, pivotal study. In this study, patients received 2 mg/kg per week of JAD141 for 52 weeks and continue to receive the same dose in the extension study. First of all, I would like to share the result indicating the importance of the heparan sulfate level in the CSF as a biomarker and MPS II. CSF HS level before JAD141 treatment were plotted in this graph. Blue diamond represents severe neuropathic patient, and the orange dot represents attenuated patient. As you can see in this slide, all severe neuropathic patients show the CSF HS level higher than the 4,000 nanogram per ml. In contrast, almost all attenuated patients show the CSF HS level lower than 4,000 nanogram per ml. Though there is a slight overlap here, but from this result, it suggests that CSF HS level can predict the disease severity in MPS II patients, and treatment goal with the JAD141 could be to decrease the CSF level in the severe neuropathic patient to the comparable level in the attenuated patient, or even lower. Here I'm showing the most significant result obtained in the completed study. In both severe and attenuated subjects, CSF HS level decreased immediately after starting JAD141 treatment and remained at a low level afterward. And importantly, when we look at the severe neuropathic subject data, almost all CSF HS level concentration decreased to the level typical for the attenuated patient. Here, I want to share another important finding about CSF HS level. In Japan, there are 10 patients who participated in both phase 1-2 study and the phase 3 study. Between these two studies, patients switched back to the standard ERT. As you can see in this graph, the CSF HS level decreased in the JAD141 treatment period. However, its level increased when patients switched back to the standard ERT and decreased again after switching back to the GR140. So in addition to the biomarker, we have evaluated the neurocognitive development in our studies. Here I'm showing the combined data from Japan and Brazil studies. X-axis is a chronological age and Y-axis is a development age equivalent score. What we found here is that the patient who started the GR141 treatment at their young age, they continue to show the normal development after 2 years of the treatment. Even in the patient who started the GR141 treatment later, we observed the long-term stabilization of the neurocognitive function. So the importance of the early treatment is also supported by the sibling case report. So in this slide, these siblings share the same genetic mutation. Sibling 2, who started the GR141 immediately before age of 2. At age of 4, he continued to show the normal development, and his age equivalent score exceeds 42 months, the ceiling of the natural history data. In contrast, sibling 1, who is on the standard ERT, showed the development trajectory typical for the neuropathic MPS II patient. In agreement with the favorable clinical outcome in the sibling 2, he showed a steep decrease of the CSF-HS level by GR141. And his CSF-HS level at 52 weeks was a level typical for the attenuated patient, or even lower than attenuated patient at the baseline. So to our surprise, we observed a significant improvement in the attenuated patient, about a 40 months increase of the age equivalent score in the 24 months treatment period. The improvement in the attenuated patient was also supported by the Vineland data, another clinical outcome assessment. So Vineland 2 Adaptive Behavior Scale is an interview-based assessment to evaluate subject communication, daily living skill, and socialization. As you can see in the left panel, most attenuated patients showed improvement in this domain, especially in the daily living skill. So these results suggest not only the severe neuropathic patient, but also the attenuated subject can benefit from GR141 treatment. So in Japan and Brazil, positive behavioral change have been reported. For example, increased word count, increased number of conversation, and resumed singing. And most importantly, most patients showed improvement in the liveliness and expression, no matter what age they started the GR141 treatment. So somatic symptom control is also important for the MPS II patient. Today, I'm showing the liver and spleen volume data because they are sensitive and have been widely used to monitor the somatic symptom control. I switched the subject who received standard ERT before GR141 treatment and the switch to the GR141 in our trial shows a stable liver and spleen volume. So liver volume remained within 5%, as you can see here, and the spleen volume remained within the 10%. And in naive patients, as we observed a significant decrease in both the liver and the spleen volume. So these results demonstrate that control of the somatic symptom by GR141 is comparable to the standard ERT. In summary, we found the CSF-HS levels appear to be a good predictor of CNS disease severity, and the reduction in the CSF-HS below the 4,000 milligram per ml was observed in almost all subjects. And in a good agreement with the CSF-HS reduction, most patients benefit from the long-term stabilization or improvement of a neurological function. And to our surprise, we observed the dramatic improvement in the adult attenuated patient, and the importance of the early treatment was emphasized by the sibling case report. And as to the safety, GR141 generally well tolerated, and all SAEs considered unrelated to GR141. And IAR was observed, however, they were manageable. And the long-term safety of GR141 was confirmed based on the 2 years of clinical experience. So lastly, I would like to share the global phase 3 study design, which we are about to start this summer. As you can see, there are two cohorts, cohort A and cohort B. Cohort A is a neurologist who are best suited to demonstrate the neurological benefit, which may take longer than the 12 months. So the study duration for the cohort A is 24 months. So we understand 2 years is a long time for the neuropathic subject. So the subject had the option to switch arm if the clinical decline is confirmed. Cohort B is attenuated subject. They are best suited to demonstrate the somatic disease control, which can be demonstrated within the 12 months. So the study duration for the cohort B is 12 months. To close my presentation, I'd like to thank all the patient and their family and all the investigators participated in our GR141 trials. Thank you very much for your attention.
Thank you. Thank you very much for your nice presentation. There are a few questions. That one is if you found difference between eperal sulfate levels in the two doses, 2 and 4 milligrams per kilo.
This is very interesting. We didn't see the difference in the heparan sulfate reduction between 2 and 4 mg per kilo. So that is why we selected the 2 mg as optimum dose for GR141.
And the other question says, did you assess neurofilament light change to look for evidence on reduced neurodegeneration?
No, in the clinical study, no, we didn't assess that, but that is very good suggestion.
Okay, I think there are no more questions. So thank you very much, Sari, for your presentation. We will move to the next one. The next presentation is by Dr. Professor Anna Bakabiev. I hope I say your surname well. She's originally a pediatrician, but now she's been in research for some years, and she has a broad experience in teaching and in research. She's now the Senior Director of Development in Denali Therapeutics, and she's going to talk to us about the results of another intravenous therapy, blood-brain therapy for MPS II.
Thank you so much for this introduction and this opportunity. I'm excited to present interim results of a phase 1/2 study of DNL310 in patients with MPS II. Is systemically delivered and is designed to have extensive tissue penetration. DNL310 is a fusion protein of IDS with the TV, which binds the transferrin receptor, or the TFR, and crosses the blood-brain barrier via receptor-mediated transcytosis. High expression of the TFR on brain capillaries and optimized affinity of DNL310 to the TFR facilitates widespread biodistribution of DNL310 in the brain. Expression of TFR on other cells facilitates IDS delivery to peripheral tissues such as bone, cartilage, and heart. The DNL310 phase 1/2 study is an open label 6-month study with an 18-month safety extension. DNL310 is administered by weekly IV infusion. Approximately 30 patients are enrolling into 3 cohorts, which have differences in patient population and dosing, and which you can see depicted on the dosing schema on the right. Cohort A is a within patient dose escalation cohort and includes neuronopathic patients 5 to 10 years old. Cohort B is a dose-finding cohort to evaluate 3 dose levels in 3 subcohorts and includes neuronopathic and non-neuronopathic patients 2 to 18 years old. Cohort C is starting enrollment of neuronopathic patients less than 4 years old or siblings. Dosing in cohort C and dose modifications in cohort B are being determined by emerging safety and biomarker results. Eligible patients are either treatment naive or on approved IDS therapy for longer than 4 months. And importantly, IDS-treated patients will be switched to DNL310 without a washout period. The primary endpoints are safety, including adverse events, infusion-related reactions, and total urine glycosaminoglycans, or GAGs. Secondary endpoints include CSF heparan sulfate, plasma PK, anti-drug antibodies, and urine HS. And exploratory endpoints include CSF biomarkers, for example, lysosomal lipids and neurofilament light chain, urine and serum biomarkers, for example, HS and NFL, and clinical outcome results in cognition, behavior, and global impression. Why can I not advance? Oh. Okay. The demographics for cohorts A and B are shown here. The age in both cohorts is 6 years. All 17 patients were on IDS treatment prior to enrollment, and all were neuronopathic except for 1 patient in cohort B. There are 5 patients in cohort A, all of whom have completed the 6-month study. Cohort B enrollment is ongoing. 12 cohort B patients who have completed 12 weekly doses are included in this interim analysis. And the largest racial group is white, and the majority of patients is not Hispanic or Latino. The following interim data will be presented. Available safety data up to weeks 43 and 25 in cohorts A and B respectively. Biomarker data from 5 cohort A patients up to week 24, including CSF, urine, and serum HS, CSF lysosomal lipids, specifically GM3, BMP, and glucosylceramide, serum and CSF NFL. Biomarker data from 10 of the 12 cohort B patients who had CSF samples available for analysis at the week 13 data cut are presented as well, specifically CSF HS and GM3. And for the first time, clinician and parent or caregiver global impression scales of change up to week 24 in cohort A. Here's our interim safety summary. All enrolled patients remain in the study with no discontinuations. All 5 patients in cohort A and 2 patients in cohort B have completed the study period and are continuing in the safety extension. An independent data monitoring committee has reviewed all the data and recommended continuing the study without modifications. All treatment emergent AEs were mild or moderate, except for 2 severe TEAEs. They were both infusion-related reactions in 1 patient. IRRs were the most common TEAEs, occurring in 1% of patients. The majority of patients had mild or moderate IRRs. 1 patient had severe IRRs. Of the 12 patients with IRRs, 8 required standard interventions to prevent subsequent IRRs. Most IRRs to date occurred between weeks 3 and 6. And of the 3 patients who experienced IRRs and have advanced to the safety extension, most pre-infusion medications have been discontinued. There was one SAE, a mild IRR, in one patient in week 4 with hospitalization for overnight observation, and additionally 2 SAEs in one patient, both severe IRRs that met Sampson criteria of anaphylaxis at weeks 3 and 4. This patient was managed with pre-infusion medications, dose and infusion rate reductions. He remains in the study and has tolerated weekly doses, including dose increases. There were no notable abnormalities or trends in safety laboratory evaluations except for anemia. 4 patients had TEAEs of anemia, 2 in each cohort A and B. All events of anemia were considered not related to the study drug. Anemia was graded mild in 3 and moderate in 1 patient, and anemia improved in 2 and resolved in 2 patients despite continued dosing at 15 or 30 milligram per kilo weekly. We concluded that weekly infusions of DNL310 of 3 to 30 milligram per kilo are generally well tolerated. Next, we looked at total urine GAGs as a measure of safety. So you can see on this, each panel represents one cohort. Total urine GAG levels were measured by colorimetric CAP and CLIA certified assay. After switching from IDS to DNL310 without a washout period, total urine GAG levels declined in almost all patients, suggested added peripheral activity. Now on this slide, on the left, you can see a serum HS graph with a blue bar on top. This graph is from a publication by Bala et al. It's a pioneering publication that characterizes GAGs, lysosomal lipids, and NFL in children with MPS II compared to non-MPS controls. The MPS II patients are either on approved IDS therapy or received HSCT. The relevant biomarker graphs from these publications are included in the subsequent slides. So here you can see serum HS in MPS II patients, and you can see that serum HS is 2.4-fold higher compared to non-MPS controls. In cohort A, serum and urine HS was measured by mass spectroscopy, and both declined after switching from IDS to DNL310. All patients had normal urine HS at week 24. CSF HS levels in MPS II patients are 10.7-fold higher than in non-MPS controls. DNL310 is specifically engineered to cross the blood-brain barrier and to reduce HS. After switching from IDS to DNL310, CSF HS normalized in all patients. Remarkably, 12 patients had normal CSF HS by week 7. These data demonstrate that DNL310 crosses the blood-brain barrier and reduces CSF HS. The effect is rapid and sustained. DNL310 is engineered to be taken up by neurons and glia in the brain. Reduction of GAGs is hypothesized to improve lysosomal function. In order to test this hypothesis, we measured CSF levels of lysosomal lipids as biomarkers of lysosomal and cellular function of neurons and glial cells in the CSF. One of them, the ganglioside GM3, is 3.7-fold elevated in the CSF of MPS II patients compared to non-MPS controls. After switching from IDS to DNL310, CSF GM3 reduction is observed. Across all cohorts, 10 patients achieved normal CSF GM3 levels to date, including at lower doses. The reduction of GM3 is consistent with improved lysosomal function. Additional lysosomal lipids were measured in CSF. CSF BMP and glucosylceramide are elevated 1.3 and 2.4-fold respectively in MPS II patients compared to non-MPS controls. In cohort A, DNL310 treatment led to reduction in CSF BMP and a directional decline in glucosylceramide consistent with improved lysosomal function. Next, we explored neurophilia, a non-specific biomarker for neurodegeneration. Serum and CSF NFL are elevated by 7.2 and 5.4-fold respectively in MPS II patients compared to non-MPS controls. 3 patients in the DNL310 phase 1/2 study were also in cohort A of this study were also in Denali's observational natural history study prior to enrollment in the phase 1/2 trial. The serum NFL data from these 3 patients is depicted in the top middle panel. And you can see that serum NFL markedly increased over the months prior to the first dose of DNL310. After switching from IDS to DNL310, cohort A participants displayed a modest increase in serum and CSF NFL at week 24. Within patient variability of NFL levels was seen pre and post DNL310 treatment, which is especially apparent when multiple serum samples were taken within a span of a few weeks. Overall, we concluded that the utility of NFL as a treatment response biomarker in MPS II will require further investigation in the field, including additional natural history data. Clinician and parent or caregiver global impression scales of change questionnaires were used to rank overall MPS II symptoms, cognitive abilities, behavior, and physical abilities on a 7-point scale from very much worse to very much improved. Worsening is depicted in shades of red and improvement in shades of blue. Cohort A patients, all between the ages of 5 and 8 years, were evaluated by expert clinician and caregivers at 4 time points from week 5 to 24. Interim assessment of clinical outcomes suggests improvement in overall MPS II symptoms, cognitive abilities, and physical abilities in the 5 to 8-year-old neuronopathic patients from cohort A. Examples of the comments from the investigator includes language much improved, more complex sentences, now able to hold a pencil, more conscious of conversations surrounding him, physical features are much improved, building much more complex Lego towers, better stick figure drawing, using new words like tangle and disgusting, and completes 3 to 4 word sentences, less aggressive, following directions. Here's a summary of all the data I have shared with you. DNL310 appears to have a favorable safety profile at doses up to 30 milligrams per kilo weekly. All 15 patients with available CSF samples achieved and sustained normal CSF-HS levels. Exploratory CSF lysosomal lipid data supports beneficial effects of DNL310 on lysosomal function. DNL310 effects on GAGs and lysosomal lipids was observed at all dose levels, including 3 milligrams per kilo weekly. The utility of NFL in MPS II requires further investigations from the field. Early exploratory clinical outcomes data suggests clinical benefits. Special thanks to all the patients and their families that generously participated, and thanks to all our collaborators. Thank you for your attention, and I'm happy to take any questions.
Thank you very much. Yeah, sorry. Thank you very much for your presentation with these really well-studied patients and your nice results. There's one question that says, the clinical study protocol should prevent a draw of too much blood. How did you conclude that anemia was not treatment related?
We concluded this because the anemia during the study, especially in cohort A, where each patient undergoes dose escalation, we draw really up to the maximum amount of blood we are allowed to draw in the first 12 weeks of the study. And the anemia was observed during this time. The nadir of the hematocrit was at week 13. And after that, we saw an improvement in the hematocrit. And the anemia did not worsen despite the continued dosing and the dose escalation to 30 milligrams per kilo.
Okay. Thank you. There's another question. What do you think is the optimal dose going forward, given the immunogenicity profile of DNL310?
This is a very good question. We're still trying to determine the optimal dose. Currently, all we can say is that we appear to have a very broad therapeutic range based on safety up to 30 milligrams per kilo and some evidence of efficacy based on the biomarkers at 3 milligrams per kilo. So we will determine the best dose going forward on still emerging incoming safety and biomarker data.
Okay, thank you. Another question. why was CGI preferred over Vineland or other scales in the patient assessment?
We are also gathering data on the Vineland and other neurocognitive assessments, but we don't have enough data and not enough time frame yet to present them. So that will be coming in the future at some point. But we are assessing these assessments like everybody else in the field. Okay.
And I understand there's too few patients to differentiate one ages from the others, no? Because 5 to 8 is a big gap for neurocognitive patients. So I imagine with 5 patients, you cannot find differences between one to the others yet.
With those 5 patients, they were in cohort A, they were all neuronopathic and they were relatively advanced in their disease. Okay. We were actually quite, we are surprised that we saw such a strong response, positive response in the global impression scales from the clinician and the parent caregiver, and they were consistent. So we think this is a very encouraging sign.
Okay, thank you very much, Anna, for your nice work. If any of the people that are listening have more questions for any of the different speakers, at the end we can have 5 minutes to include some new questions if you are thinking about them. Our last speaker is Professor Esther Bernardo. She's originally a pediatric oncohematologist, and now she's an investigator in San Raffaele Teleton Institute for Gene Therapy in Milan. And she's going to talk about the other promising treatment for MPS I patients, that is the favorable results in the hematopoietic stem cell gene therapy trial. Thank you, Maria Esther, and we're ready to hear you.
Can you hear me?
Yeah, perfect.
Yes. Thanks. Thank you for the introduction and good afternoon, everyone. And first of all, I would like to thank the scientific committee for having chosen our abstract for an oral presentation. And it is a pleasure for me to present our data on the first in human phase 1/2 clinical trial of hematopoietic stem cell gene therapy for earlier patients. Oh, thank you. It was not in presentation mode anymore. Thanks. Apologies for the mistake. So these are my disclosures. And as you all well know, Earler syndrome is the most severe phenotype of mucopolysaccharidosis type 1, and it is caused by loss of function variants of the IDO-A gene, coding for the enzyme alpha iduronidase and leading to glucosaminoglycan accumulation throughout peripheral organ and the central nervous system. And somatic clinical manifestations include coarse facial feature, bone disease known as dysostosis multiplex, brain atrophy with progressive neurocognitive regression, and a number of other systemic manifestations. And even with the best supportive care, death occurs within the first 10 years of life in these children. And available treatments are enzyme replacement therapy, which is ineffective on the central nervous system and the bone, and allogeneic hematopoietic stem cell transplantation that has to be performed early in life to optimize clinical outcomes. However, also allogeneic transplantation is associated in the long term with limited efficacy on some difficult to target organs, such as the bone and the central nervous system. And with these limitations in mind, we have designed a novel strategy, which is based on the genetic engineering of autologous hematopoietic stem and progenitor cells to drive supranormal IDO-A activity that distributes to the affected tissue through the turnover of the hematopoietic cell populations. And autologous hematopoietic stem cells are mobilized in the peripheral blood, collected and genetically modified with a lentiviral vector coding for the IDO-A gene. And cells are manipulated ex vivo with a novel transduction protocol, which is based on a shortened timing culture and the addition of prostaglandin E2 to increase gene targeting efficiency. And patients receive a conditioning regimen, which is based on chemotherapy, and it is both myeloablative and lymphoablative. And our primary endpoint of efficacy is IDUA enzyme activity in peripheral blood up to supraphysiologic levels at 1 year of treatment. An enrolled patient did not display a well-matched allogeneic cord blood donor and had a preserved neurocognitive function. This table summarizes patient characteristics at time of treatment. Of the 8 patients that we have treated, 6 are males and 2 females. Their median age at treatment was 23 months with a range between 14 and 35 months. Their median follow-up is now 24 months, ranging between 12 and 14. Here you can see the different IDUA protein variants. You can see that all patients had an IQ-DQ before treatment above 70. And all patients were able to collect and infuse a very good number of CD34 positive cells after gene manipulation. And all patients showed a prompt and sustained hematopoietic recovery after transplant with a median neutrophil and platelet engraftment occurring on day +20 and in day +14, respectively, with very low red cell and platelet transfusion requirements. And adverse events were generally mild and compatible with myeloablative conditioning regimen. At 12 months, as you can see over here, all 8 patients showed sustained engraftment of gene-corrected cells and IDUA levels, which were supraphysiologic above the 97.5 percentile of age-matched healthy children, and had a steep decline in the levels of heparan and dermatal sulfate in urine, reaching normal or near normal values already at 1 year after gene therapy. In contrast, MPS I-H patients undergoing allogeneic transplantation showed low normal blood IDUA activity at long term after allotransplant and above normal urinary GAG excretion at 1 year of follow-up, suggesting a less complete metabolic correction as compared to gene therapy patients. In terms of IDUA immune response, all patients but one received enzyme replacement therapy before gene therapy, and patient 001, who was ERT naive before gene therapy, did not develop any IDUA specific antibody after treatment, and patients who were antibody positive before gene therapy because of enzyme replacement therapy cleared their antibody titers by day 60 after gene therapy and remained negative at last follow-up. IDUA activity was detectable also in the cerebrospinal fluid, starting from the first time available, which is 3 months after gene therapy, and persisted up to the latest follow-up. GAG levels in the CSF in parallel declined with treatment, suggesting a rapid and profound metabolic correction also of the central nervous system. And brain MR showed improvement in some of the typical radiological disease features, including perivascular space dilatation and white matter abnormalities. And all patients progressively acquired motor skills, as demonstrated by the stability of motor quotient score measured by Peabody scale. And while the duration of the observation is still limited for the evaluation of neurocognitive endpoints, progressive gain of cognitive skills was observed along the follow-up, regardless of whether the IQ-DQ score at baseline was normal or below average. After gene therapy, we observed a rapid improvement of various typical clinical manifestations of the disease, which were evident at time of treatment. For example, coarse facial features, hepatosplenomegaly, the corneal opacity, or the joint stiffness. And these manifestations showed improvement or stabilization at 1 and 2 years after treatment, resulting in a milder phenotype, including improved facial dysmorphism, improved joint mobility, and upper airway obstruction, improved corneal clouding, and also stabilization of head circumference growth. And growth was measured as a surrogate for musculoskeletal disease manifestation. And despite with a limited duration of follow-up, patients continue to grow normally and in line with WHO growth charts. To quantify joint stiffness, we employed a range of motion, which were measured at several joints, such as the shoulder, the knee, and the elbow in patients before and after gene therapy. And we observed a progressive improvement in each joint, which became apparent already 6 to 9 months after gene therapy. And in conclusion, I hope I have convinced you that hematopoietic stem cell gene therapy for Earler syndrome is safe and tolerable, with an hematopoietic recovery which is in line with that of autologous hematopoietic stem cell transplantation. We did not observe any immunogenicity against the transgene. We have evidence of extensive metabolic correction, with all patients achieving supranormal blood I2A enzyme. We have demonstration of I2A activity in the cerebrospinal fluid and sustained detoxification of GAGs both in urine and cerebrospinal fluid. We also have shown some preliminary evidence of clinical efficacy in terms of motor skills and joint stiffness, as well as normal growth. And we have observed so far stable cognitive and language scores and improvement in some of the typical MR changes. And in conclusion, I believe our data demonstrate a favorable safety profile of hematopoietic stem cell gene therapy in earlier patients, along with encouraging metabolic and early clinical outcomes, thus supporting further clinical development of this treatment approach in this disease. And finally, I would like to thank all my colleagues at San Raffaele Teleton Institute for Gene Therapy in Milan, both in the ward and in the lab for the preclinical development. And in particular, I would like to thank Bernard Gentner and Alessandro Aiuti, Luigi Naldini, and Fabio Ciceri. And thank you very much for your attention.
Thank you very much, Maria Esther, for your nice presentation. We will wait 1 minute to see if there's any question. Okay. Was there any difference found between the smaller patients or the older patients? I know that's not a big range of age between them, but it's really different for HCT if patients are smaller than 2 years of age or bigger. Do you think this is a factor that can affect the results?
I think it will be a factor, as in allo transplant. Of course, the number of patients treated is limited, is only 8, but we have a couple of patients who were treated at 14 months of age, and indeed they started in terms of cognitive function, but also in terms of in terms of joint stiffness and growth. They started with a better pattern. And these patients continue to grow and develop according to normal subjects, according to peers, whereas those patients that were treated in a later stage, of course, receive gene therapy with a more advanced disease and are delayed in outcome. Despite this, they continue to develop and to grow. But of course, I think this, so far, with a limited duration of follow-up, which is median 2 years, we still see a difference between the early treatment and the later treatments.
There's one new question. Why lymphablative element to conditioning?
There has been a long reasoning about this. One of the reasons was that we were afraid of the immunogenicity of the transgene. So we know that and you all know that earlier patients receiving enzyme replacement therapy develop I2A specific antibodies. And we were afraid of patients developing antibodies against the transgene, which would have mean important disadvantages. And based on mouse model data that we had on the formation also, not only of antibodies, but also of specific T cells against the transgene, we decided to be on a safe side to use also fludarabine, which is a chemotherapeutic agent, which specifically depletes T cells and also B cells. And we also used a dose of anti-CD20 monoclonal antibody rituximab, which is specifically to deplete B cells. And this was indeed to make sure that we did not see any response against the transgene. And this was the case because, as I showed you, there is no patient with specific antibodies, and also T cell response is not present. This was done as a research endpoint, but I can anticipate we don't see any T cell response. So we might decide in the future to reduce the dose of lymphoablation or to remove. But in this first trial, that was a choice for safety.
Okay, there's another question. Can an 8-year-old child that has already received the bone marrow transplant when he was small undergo another transplant with gene therapy? What will happen? This is a general question. This is, I imagine it's a family question, but it's common for all our patients. Will our transplanted patients will be able to receive gene therapy?
Unfortunately, at the moment in all phase 1-2 studies, also because of safety, patients who received allogeneic transplantation before are excluded. So having had an allo transplant is a criterion for exclusion in these strategies. And there are several reasons for this. Again, the main is safety, and I don't want to go into details because it would be a little bit more boring maybe, but hopefully in the future this might change. What we need to demonstrate if we want to give gene therapy to patients who previously received allogeneic transplantation is that there is no more trace of allogeneic cells from the donor, because if there is a mixed chimerism, which means the persistence of donor cells from the allotransplant and patient cells, this may cause severe immunological complication that would make the gene therapy dangerous. So this is why we don't do at the moment, but this is something that might be reevaluated in the future once the gene therapy approaches become more broad and more used. And it's an important question. I really see the point of making this question for those patients who received allo and may aspirate to receive gene therapy, but this is not possible today.
There's another question. In phase 3, will you consider shy patients that are diagnosed later, or will you focus on smaller MPS I Harle?
Again, it's a very good question. Thanks for asking. In the phase 3, there will be earlier only at the moment, but there is an interest from us and also from the company to develop gene therapy also for the less severe forms. So this will be discussed in the future. Since the safety profile has been very good with this gene therapy, I think we can consider in the future to treat also less severe patients, but we really needed to demonstrate the safety of the approach before going to less severe patients. But it's a good consideration.
Okay, thank you very much. I would like to thank all the speakers. We have a few minutes of time, and there are 2 questions for Dr. Sarei and Dr. Satoshi. I don't know if they can open their videos or answer. You hear me? Ah, yeah, Dr. Satoshi is here. You are muted, Dr. And here is a difficult question for Dr. Satoshi, but I think it's a question for all our speakers. What is the best solution for a small MPS I patient? Bone marrow transplant or gene therapy? Both together. I don't know, Dr. Satoshi, this is a question for you. I understand it will also include the option of ERT, modified ERT. But because this is what we have asked you to
so thank you for asking, and it's wonderful to be developed various treatments such as IT or ICV administration and modified enzyme like us, gene therapy, and so on. And to combine them may be also good, I think.
Or use it until the transplant. Dr. Maria Esther wanted to answer, I think.
Can I say something which is just to have some clarity? So I think in the future, gene therapy, ex vivo gene therapy may become an important option for earlier patients. We still need to demonstrate its superiority as compared to allogeneic transplant. And to do this, as you well know, we need a longer follow-up because the current follow-up is too short, despite the results are very promising. So currently, standard of care for earlier patients is allogeneic transplantation as soon as possible in life, and we definitely give the indication to do this. And I think in a reasonable time frame of few years, we will know whether the superior metabolic correction that we are able to achieve with gene therapy will also translate into a better clinical outcome. In that case, a gene therapy might become a better option than allo transplant, but so far it remains an experimental.
Okay, what is true is that if previous to allotransplant we have an ERT that improves neurologic and involvement, that is surely a better option than an ERT that doesn't cross the blood-brain barrier. There's a question for Sairei, and this question says, do you think Japanese regulators approve the treatment based on CSF heparan sulfate reduction as a biomarker? Because cognitive improvements are difficult to measure or the period of time is too short for results?
Yes, in our pivotal study, the primary endpoint was CSF just reduction. However, as a secondary endpoint, we demonstrated the neurological benefit in at least 1 year and submitted to the Japanese regulatory agency. So I believe that the Japanese regulatory agency. Yeah.
Because heparan sulfate alone, we have learned that the reduction is not enough to ensure a clinical. Okay, thank you very much. There are no other questions for the moment. If any of you want to say anything to conclude, feel happy to participate. If not, I think we can finish here. I would like to thank all the speakers for their very, very nice presentations and the very interesting future for our MPS patients. That is really amazing. It will be difficult for us to choose and to decide, but it makes a big change of what we have now. So thank you very much, and we will see you in 10 minutes in the plenary session. Thank you very much.